All right, it looks like everybody is starting to come in. Welcome, everybody. I'm going to do a couple of housekeeping reminders as we get started here, and we'll give everybody a few more moments to connect with us. I'm your IT guy tonight, so hopefully everything runs smoothly, especially when we get in the breakout session portion of the program. That's always a hair-raising experience for me, but I think we'll get through it. As a reminder, tonight's program is being recorded, of course. We are on Zoom. We try to keep it as a regular Zoom, not a webinar, to give you a little bit more ability to interact with your other participants tonight. But we do ask you to utilize good Zoom etiquette as far as making sure you stay on mute as much as possible and use your camera wisely. As our speakers start presenting tonight, of course, they'll share their screen. And one of the trademarks of our program is some Q&A and discussion time after each presentation. So feel free definitely to ask any questions as we go through, and use your chat box as well to type those in for each of the presentations. This is CME accredited tonight, as well as the first night of our annual meeting. So at the conclusion of tonight's program, I'm going to pop up a QR code, which will give you access to your evaluation form that you can complete tonight. But don't worry if you don't get that. We're going to email everybody that same link so you can complete your evaluation form. And once you do, that'll trigger us to send you your CME certificate to you via email. Since this is a national group, we don't report to your state licensing bodies. You'll need to do that on your own, but we will give you a certificate for the hours that you have participated tonight. So I think we have everybody in. Again, we do have a few main presentations tonight, and then we're going to do our breakout sessions in the second hour. So I'll come back on and give you guys some instructions on how we're going to do that. But basically, you're going to self-select which breakout room you want to go into. So we'll launch them. You'll pick which one you want, and you'll be able to participate in that presentation when you go. So I think I have delayed long enough. There's a couple other folks joining us, but tonight's real host is Dr. Switzer, who is the past president of the IGFS and FFN US, and she is actually going to moderate and lead us through tonight's program. So Julie, thanks so much for doing that, and I look forward to you shepherding tonight's program.
Thanks so much, Fraser, and thanks to all of you for joining us tonight. It's great to see so many familiar faces and some new ones too. This is the second night, as Fraser mentioned, of the IGFS 2026 annual meeting. And if you didn't have a chance to attend the first meeting about 2 weeks ago, Fraser will provide a link at the end of tonight's talk when he describes how to get CME credit, and you'll be able to view it. I'll just say briefly, at that meeting, the format was a little bit different, and there were some excellent general talks, one on AI and bone density evaluation, another on age-friendly health systems and geriatric trauma centers, and how we can leverage the work we do in our geriatric trauma centers to meet the age-friendly healthcare goals. There was something on ambient listening. We had a Blue Book update, and then also just a brief teaser about our conference in December, early December of this year, 2026, in Columbus, Ohio, where we're going to have some interactive on-site meeting promoting geriatric orthopedic care, best care, and research. So more to come on that. Without further ado, I want to introduce our first speaker, Dr. Rozalina McCoy. She was at Mayo for many years, but she's now at the University of Maryland. She's a clinician scientist, an endocrinologist, and she's going to talk with us about GLP-1s and osteoporosis. Thanks so much.
Thank you so much, and thank you for being here and for your interest. So let me share my slides. And I'll dive right in. and really grateful for everybody's attention. So I have no disclosures, but very grateful for everybody's research support. So what I'm hoping to cover in 25 minutes, so we'll brace ourselves, is kind of an overview of GLP-1 receptor agonist physiology and clinical applications, review the mechanisms for effects on bone metabolism specifically, talk about some current evidence on bone effects and fracture risk, and then identify knowledge gaps and future research direction, hopefully to inspire you to answer these questions in the future. So I think we're all here because we all heard about GLP-1s. They are truly everywhere. Starting with 1982, when the glucagon-like sequence was first identified in fish, to now having thousands of publications every year and $22 billion market in 2022, which is estimated to reach over $100 billion this year and estimated at $200 billion by 2030. So it is an incredible market. It is everywhere, and patients are asking about it. And as we think about GLP-1s, they really evolved. So I'll be talking primarily about the newer therapies like semaglutide with a much longer half-life, but the early agents for which most of the evidence is available are still the earlier kind of once daily, shorter acting agents. And we'll talk about kind of the importance of that for our understanding of bone effects shortly. So kind of so I'm a diabetes, obesity person, so very grateful to be here with all of you. But I think the reason we're here is really the intersection of converging epidemics. We have a rising use of GLP-1 receptor agonists as they are approved for type 2 diabetes, for obesity, for metabolic associated steatotic liver disease, cardiovascular risk reduction, and many expanding indications with multiple ongoing trials. As the prevalence of diabetes and obesity is rising, more people are using these therapies. As people age, there's more osteoporosis. We know that type 2 diabetes is associated both with osteoporosis, with an increased bone fragility, but also diabetic osteopathy, which is a separate disorder which differs from postmenopausal osteoporosis, right, with multiple different mechanisms such as advanced glycosylation and product accumulation in the bone matrix, altered osteoblast function, uncoupled bone remodeling. A lot of things kind of happens in diabetes that is separate from regular osteoporosis, and that's all potentially impacted by GLP-1s. So we need to understand how all of this comes together in our patients. So the American Diabetes Association, in its standard of care, talks about bone health, recognizing that osteoporosis and metabolic bone disease in general are known complications of diabetes, kind of adding on to what we traditionally think about as macrovascular, right, so cardiovascular and microvascular diabetes complications. However, the guidance for diabetes management and osteoporosis isn't very directed, in large part because of the lack of evidence really on what to do. So we are advised in general in people who have osteoporosis and are at risk for fracture to avoid medications with a known association with higher fracture risk, particularly thiazolidinediones, so pioglitazone and rosiglitazone, and sulfonylureas. And we should prioritize glucose-lowering medications that are associated with low risk for hypoglycemia in order to avoid falls, recognizing that if people don't fall, they're less likely to sustain a fracture. So again, that is prioritizing medications other than insulin and sulfonylureas. But that's pretty much it. So what is the evidence for GLP-1s? Because otherwise, I think they are critical medications in our armamentarium for the management of diabetes. So kind of a bit of an overview for those of you who don't do diabetes and obesity. Their primary mechanism of action is glucose-dependent insulin secretion. So when glucose levels are high, insulin secretion is stimulated. That way blood glucose levels can be lowered without causing iatrogenic hypoglycemia. They also cause decreased glucagon secretion, also in a glucose-dependent manner, delayed gastric emptying, and acting centrally, reduced appetite and food intake. Here you see the list of kind of currently FDA-approved GLP-1s. So the first generation, exenatide, liraglutide, and dulaglutide. Second generation with semaglutide, and now a dual GLP-1 GIP receptor co-agonist, so a cousin of the GLP-1s, or tirzepatide. In general, this class leads to between 1 and 2% hemoglobin A1C risk reduction, and the magnitude of potency kind of goes up with later generations. So exenatide would be the weakest, and tirzepatide is the most potent. They lead to weight loss between 5 and 20%. And then in patients who have high cardiovascular disease risk, they lead to between, again, 15 to 25% risk reduction in major adverse cardiovascular events. So these medications really revolutionized diabetes and obesity management by producing the amount of A1C reduction that previously we used to see only with insulin, and the amount of weight loss that approaches metabolic surgery. And that brings us to really this paradox of diabetes, obesity, and bone. As we think about what the bone effects in type 2 diabetes, obesity, and weight loss, they really it's hard to know what's going to happen, right, when you bring it all together. Because in type 2 diabetes, individuals typically have normal or even high bone mineral density on DEXA scans. However, they have an increased fracture risk, mostly due to impaired bone quality with the accumulation of advanced glycation end products. And there's altered bone turnover. Obesity has a beneficial effect. It's like the one time in clinic I tell my patients, I'm actually not going to tell you to lose a lot of weight because the increased mechanical loading that is seen with obesity is beneficial for bones. However, at the same time, there's chronic inflammation, which is not beneficial. There's increased marrow adiposity, and we do see paradoxical fracture risk. However, rapid weight loss can cause mechanical unloading, which is not good for bones. There's decreased estrogen and leptin levels, also not so good. Bone turnover increases, also not so good. And bone mineral density typically decreases. So in a way, we're stuck between a rock and a hard place in the situation. So it's hard to know kind of what happens when patients take GLP-1s where inflammation is decreased, but also there's a substantial amount of weight loss. Now, I kind of show this to demonstrate the fact that while we typically think about GLP-1s as just kind of a GI system, endocrine system acting medication, it's not. It's highly pleiotropic, and it has effects on almost every body system. And that includes the bone. A lot of that evidence for impacts on bones come from preclinical studies, and a lot of it is still in animals. So I think there's still great need for better understanding of the pathophysiology and just the effects in people. But what we know is that GLP-1 receptor agonists appear to stimulate beta-catenin, so a number of things basically that promote bone formation. And they also promote bone marrow stromal cell differentiation toward osteoblasts as opposed to adipocytes. At the same time, they appear to inhibit bone resorption, both directly and indirectly. So based on preclinical evidence, it would seem that GLP-1 receptor agonist therapy would have beneficial effects on bones. Still, most of these are in vitro studies and animal models. So, and this kind of highlights what we see in vitro and what we in vivo, and in vitro. So we think that there is a beneficial effect on bone mass and strength without impacting bone mineral density. There appears to be a beneficial effect on bone architecture. We don't really know what happens with bone turnover. There's a beneficial effect on collagen, particularly through increased blood flow to collagen and to bone. There's this question of what happens to calcitonin, especially because that's primarily seen in rodents and not people. So we don't actually know. And both osteoblasts and osteocytes have GLP-1 receptors on them, but we don't fully know what happens there. So that's still a question mark. But ultimately, I think as you can see that GLP-1 receptors are everywhere and they seem to have potential for action in multiple places. So this is all from preclinical studies. What do we know from clinical data in patients? So I'll show you a couple of meta-analyses that were done that examine GLP-1s as well as other medications. And currently the data is somewhat inconsistent. So this meta-analysis looked at compared different glucose-lowering medications to placebo in people with type 2 diabetes. So that's our population. They found no GLP-1s are kind of listed here, but I highlighted the medications that had a statistically significant impact on bone compared to placebo. So we can see that for non-vertebral fracture intervention, risk is decreased with DPP-4s, GLP-1s, and SGLT2s. For hip fracture, the only beneficial effect was seen for SGLT2s. For vertebral and hip fracture combined, here it's DPP-4s and GLP-1s. And then for overall fracture, combining all of this, we now see beneficial effects of DPP-4s, GLP-1s, and metformin. So I think what this highlights is that there's a lot of heterogeneity between studies, largely because of vastly heterogeneous patient populations that are included in those studies, particularly when it relates to osteoporosis risk, since none of these studies were actually designed to evaluate impacts on fracture or assess individuals with osteoporosis or at risk for fracture. Now, in a different meta-analysis of randomized controlled trials, again, in type 2 diabetes, where bone density was assessed rather than just fracture, they generally found statistically significant increases in bone mineral density at all sites. So you can see lumbar, spine, the hip, the hip femoral neck, and then the total hip. There was also impact on some, but not all, bone turnover markers, with increase in markers of bone formation and decrease in markers of bone resorption. But overall, these studies did not find an increase in fracture risk. Now, of these 25 studies, they used different GLP-1s. 14 were liraglutide. 3 were dulaglutide. Semaglutide and tirzepatide were not included, and they're the most potent ones that we're using in practice. And these patients were generally younger, so their average age in these trials ranged between 40 and 64 years old, which again highlights kind of who's included in these diabetes studies and why this may not be the most appropriate population to assess fracture risk. But you can see here, these are the actual data from that meta-analysis, where you can see, I think, some variability across studies, but for bone mineral density, the results are fairly consistent. So in green are the point estimates favoring GLP-1s. Same for, and the comparisons here were a wide range of other diabetes medications. So this is not placebo, this is kind of a mix of other drugs. So again, you see here favorable effect on hip bone mineral density, femoral neck, but no difference in fracture with a very wide spread. But again, this is a younger, lower risk population, so the event rate was fairly small. As you can see here, how many between 0 and 4 events, right, in the experimental group and 0 to 5 in the control. So these are not the best powered studies. So other meta-analyses found different results. So another one that looked at a different set of RCTs of GLP-1s, also in type 2 diabetes, found a pooled a hazard ratio of 0.76, so a 24% risk reduction in fracture. Now, this meta-analysis didn't actually say what fractures they were looking at. And importantly, what they found is that this benefit was only seen in patients who stayed on treatment in those trials for more than 78 weeks. And when they looked at individual drugs, it was only significant for liraglutide, not for any of the other ones. And they didn't even report on semaglutide, which is Ozempic. So I think part of me just thinks that they ran a lot of comparisons. But I think, again, underscores the state of the field with a lot of unknowns. This is a different study, a different meta-analysis of GLP-1s where they looked specifically at diabetic osteopathy indicators. So the hypothesis is that bone mineral density is not we should look at it because it is an indicator of osteoporosis, but it's not really an indicator of altered bone metabolism and fracture risk because of diabetes effects on bone strength and quality. So we need to look at bone resorption and bone formation markers. So here you can see we show the overall effect and then liraglutide and exenatide. And then they compared specifically in people who in these studies who have type 2 diabetes but not diabetic osteopathy, which they weren't fully clear how they differentiated between them. And the asterisks show statistically significant differences just for ease of interpretation. So you can see that overall, kind of looking here, GLP-1s, they significantly reduced bone resorption as measured by beta CTX, while simultaneously increasing bone formation. And when we look at specific GLP-1s, liraglutide had the strongest effect, which makes sense. Liraglutide is more potent than exenatide when it comes to GLP-1s. And the effect was strongest in postmenopausal women when you look at kind of the magnitude of all of these changes. So then in this meta-analysis, they did a deeper dive into really all of these subgroups. So green, again, are all the things that are statistically significant. So we're not going to look at the numbers, but more at the patterns. So overall, we see beneficial effect of GLP-1s on bone density, particularly at the femoral neck. The effect was greater in postmenopausal women than in all patients. It was also greater with shorter duration of diabetes, which likely makes sense. If you had diabetes for a long time, the damage is already done. So the beneficial effect and the potential for GLP-1s to reverse some of that damage is less. So postmenopausal women with shorter duration of diabetes, those with longer diabetes duration still saw benefit, but they had to be treated for a longer period of time. And the longer patients are treated, the more the benefit. And they calculated a number needed to treat with long-term treatment of 62 to prevent one fracture. The reason it's important to think about the long duration is that on average, kind of the patients stay treated with a GLP-1 for under a year. So most studies, depending on the study, the median duration of treatment before patients discontinue for a variety of reasons is anywhere between 6 and 12 months. Somewhere there, depending on the study. And patients discontinue because of side effects, because of cost, because of shortages, insurance coverage. There's a wide range of issues. But if we really see benefit on bone with prolonged use, then the way that these medications are used in real world practice, we may not see those effects, which again makes it difficult to study these medications in kind of more at higher risk populations that are included in clinical trials. This meta-analysis also compared the effects of GLP-1s to other either glucose-lowering medications and to bisphosphonates. So you can kind of see how they compare to each other. So this is overall bone density and bone turnover marker changes and fracture, relative risk for fracture. And then they compare them to each other. Especially, I think the interesting comparison is GLP-1s with bisphosphonates. So you can see that both GLP-1s and bisphosphonates improve bone outcomes. The number needed to treat was 62 for GLP-1s and 45 for bisphosphonates. When we compare them together, GLP-1s are less effective than bisphosphonates, but only by about 25%. So I think to me, it kind of shows the potential in patients who have shorter duration of diabetes and can stay on a GLP-1 for a long time to impact bone. And GLP-1s are generally superior to SGLT2s, which is another commonly used medication class with cardiovascular and kidney benefits in type 2 diabetes, but without the significant weight loss effects. So it's interesting to compare GLP-1s to metformin, which is weight neutral, and SGLT2s, which are slightly weight loss inducing, and kind of see the differences there. So together, this data seems to suggest that there is likely a benefit in bone metabolism and possibly fracture with GLP-1 use. Now, all of this is for people with diabetes. People without diabetes are different, right? They have different underlying bone dysfunction. And this is the only study that I could find that looked at bone effects of GLP-1s. And they studied semaglutide here in people who have obesity, but do not have diabetes. So in this trial, they looked at changes in bone turnover markers as their primary outcome in 52 weeks. It was a very small study, just 55 postmenopausal women and 9 men. And what you can see here, so blue is semaglutide and red is the placebo. And you look at kind of bone turnover, beta CTX and PNP here on top. And overall, you see that there was really no difference on bone formation, kind of here in A and B, between semaglutide and placebo in people without diabetes. But in people without diabetes, bone resorption appeared to increase, which would be a non-favorable effect. So this underscores that in people who do not have diabetes-related metabolic bone disease, the impact of weight loss from these therapies may in fact be detrimental. So the effect varies depending on diabetes status. Now, we can't talk about GLP-1s without talking about exercise as really a key protective factor. So there was one study that this was done in Europe, in Denmark. I don't know if this could be done in the US, but they had patients on 8 weeks of a very low calorie diet, so 800 calories a day. And they were randomized to one of 4 groups, either exercise only, liraglutide only, exercise and liraglutide together, or placebo. So you can see that on this super low diet, everybody lost about 7 kilograms. So this is actually for any obesity trial, this is incredible. They lost more with exercise, more with liraglutide, and more with both. So a substantial amount of weight loss. People with exercise alone, bone mineral density was maintained compared to placebo. It decreased in those with liraglutide alone. And in those who did both, again, bone mineral density was maintained. So this highlights that exercise, and this was moderate to vigorous intensity exercise program, is able to reduce the detrimental effects on bone with the weight loss that we see with GLP-1s. So I think clinically, this underscores the fact that both resistance and weight-bearing exercise needs to be strongly encouraged, I think required, for people on GLP-1 therapies. And this kind of shows the impact over time, kind of this, they have their low-calorie diet, and then they have the multiple interventions. And you can see here the effect on hip bone density, spine bone density, and forearm. So the forearm, where it's non-weight bearing, there's not much of a difference. But in the weight-bearing locations, there's a really substantial difference, as you can see here. So I think in kind of starting to bring it all together, it tells us that one, as GLP-1s are used for multiple indications, that context matters, whether the person has diabetes or not. So people who do not have diabetes, they'll have greater hip bone mineral density loss with GLP-1 therapies, and that appears to be driven primarily by weight loss. And that is due to the mechanical unloading in the setting of weight loss. In people with type 2 diabetes, GLP-1s are similar to other medications or even potentially better, so we don't know. But there's also metabolic improvements, there's glycemic control that also helps bone. So overall, it's either net neutral or possibly beneficial. So GLP-1 bone effects appear to differ by diabetes status. So when we think about bone effects and kind of whether I think it wouldn't be a decision of do we or do we not use GLP-1s, but rather how do we appropriately monitor and counsel patients to maintain optimal bone health when we do use them, right? So it's important to risk stratify patients. Those based on their likelihood of adverse bone events with GLP-1 therapy. So those who are lower risk are people who have type 2 diabetes and receive GLP-1s for diabetes, who are younger, who do regular exercise, and who have moderate obesity, meaning that they're likely going to be losing a net less amount of weight. And those who are at higher risk, that's people who have obesity and no diabetes, who are older, very high BMI, sedentary lifestyle, and pre-existing osteoporosis. Now, I do want to end with some things that we don't know that I personally find very interesting and maybe will inspire you to look at. So we don't really know the impact of GLP-1 therapy for orthopedic surgery if a patient has fracture. So we know that preoperative weight loss is good, right? Lower infection risk, lower complications, better wound healing, and improved function. Oh, sorry. Oh, no, wrong way. However, there's theoretical skeleton concerns with rapid weight loss during healing and unknown impact effects on the implant itself. So currently, there is no data and no guidance. So we have to think about known benefits with theoretical concerns. I think there's no reason why patients who are on a GLP-1 would fare worse and or even have them stop the therapy. I think the risk of stopping therapy outweighs the risk of not stopping therapy kind of while they're recovering in the context of surgery. But I think that's going to be important because we really just don't know what happens with fracture healing. Um, we just, we don't know. So hopefully somebody will look at this. So in summary, in the last 1 minute, I think that I have, I think we know that GLP-1s, they have substantial cardiovascular, kidney, and metabolic benefits in people with and without diabetes. There's uncertainty in fracture benefit in people with type 2 diabetes, but the existing preclinical data and emerging clinical data appear that it's favorable. Exercise provides a very strong protective effect, so we need to co-prescribe exercise with GLP-1s, and we do need to have higher caution in at-risk groups. So if somebody is borderline for, let's say, treating osteoporosis, and you're going to be giving them GLP-1s, you may lean more towards treatment. So clinically, I think it's important to assess baseline fracture risk, strongly encourage exercise, optimize calcium and vitamin D intake, monitor bone density, and add bone therapies if osteoporosis or high fracture risk is present. And I think we really need to continue looking at bone frailty, sarcopenia, and fracture effects of GLP-1 therapies. So I know this is a whirlwind, but hopefully introduce you a little bit more to GLP-1s in the bone context and sparked some excitement for further exploration. And this is my email if you have any questions.
Thank you so much, Dr. McCoy. That was just fascinating. And we have two questions to start off. Carmen?
I thought that was really great. And actually, when we were creating this programming, I think I had so many questions that you really just answered with this great summative review. And I particularly like the research questions you posed because I think as an orthopedic surgeon, one of my curiosities around, a lot of the conversations that are happening in our space is around like, should we stop it right before surgery? A lot of surgeries are like, you're not supposed to take it before you come in for 2 weeks and all these things, but we're not really talking about the impact. And I think a lot about the bone medications we give and the there's been a lot of controversy about whether we stop them and this idea of like the inflammation reduction and because GLP-1s seem to have such a systemic effect. I think your secondary points are so spot on, and I don't even have a great research way to explore it. I just wanted to thank you because I think you had some incredible slides, especially at the end, that we should all be really processing. So kudos, that was amazing. And I don't have any questions. I thought it's great.
Thank you. But I think it'd be great to even track outcomes of patients. So even as you take care of patients, if you document in the chart when is the last time they took their GLP-1, because that's going to give us the data to be able to know. That's the hard part about looking at this question using real world data is that we have no idea when patients took their last dose. And I think if we can start tracking that, we can get the data and at least start to answer some questions.
Thank you. Dr. Orwig, Denise, do you have a question or a comment?
Yes. So, Rosalina, thank you very much, a fellow University of Maryland person
Yes.
here. This was great. My question really has to do with bone density screening, right? So these are going to be like, will insurance really pay for that? Like, what do you think the viability is for really doing bone density screening in younger people on GLP-1s or even older people? Because the guidelines for when insurance will cover that. So I'm just curious what your thoughts are about that.
I think we need data to identify patients who need to be screened. I think with insurance coverage, it's very challenging because insurance currently doesn't pay for screening in other situations where it's extremely necessary, like hyperparathyroidism.
Right.
They don't pay for
Right.
that either. So I think what I do is off often. So if it's a woman, that is much easier because you can cause postmenopausal and then
Right.
you can just screen, and that's usually fine.
Yeah.
For men, it is challenging because hypogonadism isn't covered either. So often, you try to see kind of sometimes like height loss can get you covered under like high risk or suspicion for osteoporosis. If you document that, that can get them covered for a DEXA scan. Currently, it seems that from the GLP-1 perspective, the patients who are at highest risk are those who are older. So I don't think we need to be screening those who are young unless they lost a lot of weight. And there, I would use the same, personally, we have no data on this, but what I do is I use the same kind of framework as after metabolic surgery. So if they lose a lot of weight, then I actually check bone turnover markers and I can call it metabolic bone disease and then I can screen. So that's been kind of a way to do it because it's not screening anymore at that point because you identify the problem. Um, and bone turnover markers are often covered with like a severe weight loss and things like that. Yeah.
Thank you so much. Again, just echo Carmen's sentiments. Fantastic talk, really provocative.
I
And
wish I had data to share. It was hard to give a talk, and it's like, we just don't know. But I'm really hoping you guys can help look at this. So, kind of a call to action.
That sounds great. Well, thank you
Thank
so
you.
much. We'll now go to the next section of the night. And this I've been also really looking forward to. This is a review of two different PCORI projects that are looking at different interventions post-frac. No, Denise are you shaking your head? Oh, wait. Okay, I'm getting the thumbs up. Well, The two people who are presenting this evening are Sarah Berry from Harvard, who's looking at fall prevention programs, I think post-fracture. She'll tell us more about that. And then Dr. Denise Orwig from the University of Maryland, who's going to talk about multimodal interventions post-fracture. And I'm not sure who's going to go first. Sarah?
Denise, is that right? Okay. Okay to share my screen?
Be great.
It says
Yeah.
somebody else is sharing.
Yeah.
Is it Jay?
It looks
maybe?
like Jay is sharing. Hold on one second.
I'm not meaning to share.
Okay.
How do you turn it off?
I think I did for you,
Thank
Jay. Don't
you.
worry.
Oh, I pushed it again. I'm sorry.
That's all right. Dr.
Not
Barrett,
a
looks like
problem.
you're.
There we
There we
go. Am I
go.
sharing
There we
now?
go.
You are,
Yeah.
Good, good. All right. Let's see. And then if I can get it. All right, in presenter mode. Oh, okay. So again, I'm going to tell you, as you mentioned, thank you for the opportunity to speak today and for the nice introduction, Dr. Switzer. I'm going to talk about preventing injury in skilled nursing facilities through optimizing medications. We're calling this trial PRISM. Here's a bit about my disclosures. I'll say I don't think I need to tell this group how important it is to consider secondary fracture prevention, but you may wonder why focus on post-acute care population. And that's because 60% of patients, older adults who are hospitalized with a fracture, are discharged to a skilled nursing facility, right? And in particular, the patients that go to a skilled nursing facility tend to be more frail, tend to have more cognitive impairment. These are the patients who are at highest risk for recurrence of fracture. And so while post-acute care, the SNF setting, it's obviously a busy time, patients may stay here 2, even 3 weeks. It's actually probably the longest continuous period of time where they receive care in one setting. And so there's really an opportunity to adjust medications there. Furthermore, it's an opportunity to work on these transitions of care as they hopefully, again, transition back to their primary care doctor or others. So the objective of PRISM is, again, it's a randomized cluster crossover trial in fracture patients receiving post-acute care to compare the effectiveness of 3 different care models, a deprescribing care model, a bone health model, and a combined model on rates of injurious falls and other patient-centered outcomes. The recruitment for this study is occurring in 2 waves. First is at the level of the facility, right? The skilled nursing facility, where again, our target is 42 facilities. We're just, asking that these facilities participate in the long-term care data co-op, and I'll talk a bit more about that in a minute, and that they have at least 400 admissions annually, some significant volume. Optimizing people's medicines, paying attention to people's medicines after practice is considered standard of care. And so we are not getting, the consent is at the level of the facility to participate. Patients have the ability to opt out, but it's a rather pragmatic enrollment of the patient parts. As long as the patient actually had a fracture, and again, it wasn't a non-osteoporotic fracture, something like cancer or a fracture of the fingers and toes, as long as the patient isn't on hospice or sort of eligible for palliative care, or if again they're just discharged too quickly and we can't reach them. Otherwise, they're included in this program, right? So what does the intervention look like? Really central to the intervention is a nurse consultant. And this nurse consultant is remote. We actually have 5.5 of these nurse consultants working on this project at one time. They do the heavy lift of the electronic health review, looking at indications for all the medications, a bit about the patient's history, and then they contact the patient, or often it's the proxy, the representative, to learn what's most important to the patient, what their goals are, before engaging in some sort of shared decision-making recommendations about medications. They feed this back again. We have a geriatrician that runs by these recommendations, and as well as again before they give the recommendations back to the staff through these short virtual huddles. I'll say one sort of unique thing is, again, we're, in addition to communicating the recommendations with the frontline staff at the nursing home, we're coordinating these recommendations with the primary care docs when we can find them on discharge, as well as, again, delivering some patient education. The medication, at the end of the day, there's sort of three different models that we're comparing. Again, the one is focused on deprescribing meds associated with falls and injury. The second on treating osteoporosis. The third on both, the combination. And here's an example of sort of this medication optimization plan. Again, it looks a little different. This is one that we're delivering to the SNF providers. We also give a copy to the patients and the families at the time of discharge, and the primary care provider at 1 month follow-up. But we note on here whether or not we were able to reach the patient, what their priorities are. Was it comfort? Was it getting home? Was it getting stronger? Right? And again, how the medication recommendations, and this time this would be a deprescribing arm, sort of fit in with that. Once we kind of were sure up on our intervention, there was a little bit of, or quite a bit of discussion about it's sort of the right study design. And so I'll talk just briefly on how we landed with this cluster crossover. So obviously enrolling at the patient level has the advantage of minimizing the sample size and ensuring balance of covariates right across the group. But this would be extremely cumbersome, right? Getting informed consent from this large group. We know that a high proportion of these patients have cognitive impairment. We'd likely end up with a much less generalizable sample. Further, if we were offering multiple interventions in the same facility, right, at the same time, we kind of run the risk of contamination. So in contrast, if we were to randomize at the facility level, this would obviously minimize contamination and the potential waiver of consent. But again, there's some cons there, right? You take a hit in your clustering in your models, and you need a larger sample size. And even with 42 facilities, right? It's a fairly small number that you would randomize to 3 different groups. And so you might have sort of disparate groups in this randomization scheme. So we kind of took a hybrid approach, and again, this cluster crossover study design where each facility gets 6 months of each intervention in random order. And so a patient that's enters into the nursing home, they get the intervention at the time that they were at the time that they were admitted, right, regardless of whether they stay in the facility or, or discharged or readmitted, right? It's sort of the fidelity there. I'll note that in addition to the comparison, again, within facilities, sort of these 3 different care models, we are, again, looking in this long-term care data co-op, this large sample of nursing homes, and we're going to compare outcomes with matched controls. This is a list of our outcomes. Again, our primary outcome is injurious falls and fractures, again, with a target of having a mean 2-year follow-up. This will be collected pragmatically, again, using Medicare claims data. We are getting self-reported fractures because we're worried about the lag time with Medicare Advantage data. And then you'll see a host of other secondary outcomes, some of these process measures, others self-reported measures. The long-term care data co-op I'll mention, again, is there's over 3,000 nursing homes to date that are contributing their electronic health record data voluntarily, and it can be linked with both the minimum data set, this resident assessment, as well as Medicare Parts A, B, and D. Really a tremendous, tremendous resource, again, with these sort of daily levels of medications for for people that are interested in that. Here's an example of exactly how granular you can get with this long-term care data co-op. On the left is sort of looking at an average weekly pain scale of more than 14,000 nursing home patients who are admitted due to a fracture. On the right, it's their average weekly gabapentin dose. And you can see we've been grappling with how to characterize changes in medications over time, given how much information we have in this data set. To date, we've enrolled 39 of our 42 facilities, and we've achieved some variation in these. Again, about 37% are sort of the 4 to 5 stars, high quality facilities, 37% sort of mid stars, and 26% 1-star facilities. To date, we've, as of the end of January, we'd screened just 3,600 patients and enrolled over 1,700 patients in the study. You can see most of the patients that we don't enroll, it's because they don't meet the eligibility criteria. Perhaps it was an elective joint when the nurse goes in to look, it wasn't really a fracture. A smaller number that opted out. And then again, a moderate number, 640, that are, again, they're just in and out into the hospital so fast that we don't have enough time to deliver our medication plan. Patient characteristics, I'll say we're pleased with this pragmatic approach. We are getting a sort of an older population, again, median age 82 with a range up to 102 years. 34% of these fractures are hip fractures, as you might expect, 14% vertebral fractures. And dementia diagnosis, which we know is way underreported, is at 22%. I think I'll skip here in the interest of time. And I just want to comment that for those of you, if anybody is interested in this long-term care data cooperative data, it's available to use. And in fact, the linkage with CMS is actually free, which is kind of unheard of, given the collaboration between the American Healthcare Association and the NIH. I'd encourage you to look at this website, the Next Steps website. I'm a co-investigator there. It's an NIH-funded initiative encouraging work in nursing homes, and it includes a webinar series, pilot grant data funding, and other things, again, that might be helpful for people who are interested in doing research in nursing homes. So I'll end with thank you and want to leave time for Denise and others.
Thank you so much, Sarah. I think we will go on to Denise's presentation and then take a couple of questions at the end. Oh, Denise, do you have your audio on?
Sorry, I couldn't see it once I shared my slides. Sorry. Okay, you can see the slides?
Yes.
Wonderful. Okay, well, thank you so much for the opportunity, and it's really nice to have Sarah go because there's some overlap, but then there are some differences. So I'm going to be talking about my funded project with my co-PI, Patty Dykes, who has recently moved to Emory University, and our project is the options study. I have no disclosures to report. This is the clinicaltrials.gov record, and then obviously it's sponsored by PCORI. Again, I don't have to talk about the downsides of osteoporosis, but I do just want to mention something similar that Sarah also addressed, is that the care, the continuum of care for these lower limb fracture patients that we're interested in is very fragmented, right? They go to acute care, then there's this kind of black box in the skilled nursing facility, and then they go back and they're seen by primary care or specialists. And so we know that a majority of these lower limb fracture patients do go to skilled nursing facilities or SNFs for rehab. But we also know they rarely comprehensively address bone health. We know that also the care is quite varied, and it is an ideal setting, kind of as Sarah was alluding to, that they're in there for 3 to 12 weeks for rehab for a lower limb fracture. And so it's an opportunity to introduce evidence-based interventions and incorporate them into the workflow. So the study objective here is to evaluate 2 clinical decision support enabled interventions called options or study options within the skilled nursing environment to improve bone health and reduce recurrent fractures. And we're going to follow people for a year once they're discharged back to the community. So that's the group we're interested in. And both of these interventions provide education and resources for not only the residents and their family members, but also to the SNF staff to help promote reduction in falls and fractures. So our study design, we decided to do a matched pair cluster randomized controlled trial, and we're also in 42 skilled nursing facilities. Our unit of randomization is the SNF as well, but it's a matched pair. So within an organization, we select all of the eligibility skilled nursing facilities, and our criterion is they had to have at least 35 lower limb fractures in a year. And we match pairs within the organization, and we have matching criteria based on star rating, bed size, and whether they're urban, rural, or suburban. And that's how we get our pairs. So that's the cluster. We're partnering with Point Click Care. They are a large EHR vendor, and they have been a wonderful partner. They are connecting us with their customers, their organizations, and that's how we got access to these skilled nursing facilities. We are going to compare outcomes collected by telephone once they're discharged home, and we do that initial assessment, and then at 6 and 12 months, our main outcomes are function and quality of life, but then we're collecting a slew of other secondary outcomes like fractures and mortality. And our goal is to enroll 1,344 patients, 65 and older, no severe cognitive impairment, as measured in the SNF, discharged to community, and we are enrolling Spanish-only speaking individuals as well as English-speaking. And we're using a very comprehensive implementation science framework to help us make sure that we're continually engaging with our stakeholders to get valuable feedback. I'm going to put my timeline up because I don't really have a lot of results to share like Sarah did, because we started this process a bit later in the game. So we went live in one organization with 18 sites in December of 2025, which I would never recommend to anybody in the future. So please, if you're thinking about doing a study and you're going to start it in December, I would strongly advise against it, just for a variety of reasons. And then we started study enrollment for that organization in January. There's a lag because they have to be in the facility and get discharged home before we can enroll them. And then we actually went live in the second organization in February, just 2.5 weeks ago. And we will start enrollment in that facility, or in that organization in March. So I want to talk a bit about our 2 interventions, right? They're implemented within the using clinical decision support. I'm going to talk about this study options one first because it's a little less complicated. We are using the Centers for Disease Control and Prevention's Stopping Elderly Accidents, Deaths, and Injuries toolkit. It's a very well-developed fall prevention toolkit. And it used to be freely available, but now you really can't get copies, so you have to print them yourself, but that's okay. They're available and you can download them and print them easily. What's really nice is there's quite a bit of available for SNF staff training. I believe you can actually get CEUs if they participate in that. And then there's also patient education related to staying independent and checking your fall risk. So again, this is providing these resources is built in to the CDS and implemented while they're in their getting their rehabilitation. The other intervention is options, and it incorporates 3 evidence-based strategies for exercise, nutrition, and bone-enhancing medications. Again, there is educational resources for the clinicians and staff, as well as the residents and their family members, so they can reinforce the information they're learning in the SNF once they get home. So I just want to show a kind of schematic, very simplified one, but this sort of shows how we're conducting the various study activities within the SNFs. We are a little different than Sarah's study because we do need to actually enroll them to collect the data once they get home. And right now, we have no way of knowing who those individuals are in the SNF. We don't need consent to deliver the interventions, but we need them for us to call them once they get home. So in addition to what's happening below the line, this is all related to clinical decision support. And there are various staff members, depending on their role and their expertise, that would be responsible for delivering some of these activities, depending on what group that SNF is assigned to, whether it's options or study options. And there's something in admission, something while they're there, assessments or care plans, and then there's something at discharge. The top of the line shows study-specific activities related to doing eligibility screening and REDCap, which the SNF staff have been trained to do, and then also obtaining permission to contact, which is they go in and say, hey, we're partnering with this study. We think you should consider it. Is it okay for somebody from the study to call you once you're home? They can give verbal permission. The SNF staff records their contact information along with a significant other, and then we then have a way of knowing who they are and contacting them once they've been discharged. So this is an example of a screenshot of what was built into the EHR. So once we went live, for all new admissions that enter that facility, they get this question down here that says, is this new admission 65 and older with a lower limb fracture, including a pelvic fracture? If the answer is no, then you answer no, boom, you're done. You don't have to do anything else. If it's a yes, then they're instructed down here to enter into this green box. They're supposed to type in option study or study options, depending what group they're in. That will then place an instruction up here in the special instructions so that anytime anybody goes into that EHR, all the staff members will see that this person is eligible to receive the intervention components for that group that that SNF was assigned to. So this was just a really nice way for us to get the word out to everybody who accesses this chart that this person is eligible for study or eligible for options. Now I just want to show some quick screenshots of what we built into the CDS. There's way more than this, but these are just quick screenshots. So for exercise in particular related to the PTs, right, we incorporated a variety of assessments that are done on admission related to weight-bearing status, their exercise level, and any specific health conditions. And then we also here what's circled. There is a link that they can click directly from the EHR that takes them to a different page. And there are all these handouts and videos that are available for the physical therapists to use, but also to print out to give to the residents so they can start becoming familiar with these things and use them when they get home. So that's just a quick example. There's many, many more, but I just wanted to show one. This is an example of the nutrition CDS. This one is actually not all that different. Except that we really do want to strongly encourage them to do the malnutrition risk assessment, the M&A at within 24 hours of admission, as well as a few other things related to what they're actually consuming, how much they're eating of their meal. And then for bone strengthening medications, this is the piece I'm most excited about. If they come in, if they enter the facility on a bone active medication, then they can continue that medication. And it looks like data we've seen, they do tend to do that in the SNFs. However, if they're not on something, which is a large majority of people, then we want them to initiate it. And we provided a list of all the products that they could consider However, what we are seeing is that they are developing their own bone medication order set. And so each facility is choosing which medication they feel comfortable providing to people in addition to calcium and vitamin D. So that's a very exciting component for me. And this is just an example of the resources that they can access directly from the EHR for medications, exercise, and nutrition. This is the resources available to the residents. There's a workbook we give them. There are discharge summaries. There's an app, a mobile app, and then we have study information we provide in the study folder. Pragmatic trial lessons learned. As Sarah was alluding to, always try to anticipate the worst case scenario. We thought we had, but oh my gosh. So literally since July, we lost our two main SNF organization partners, which was very stressful. But because we partnered with Point Click Care, we had ongoing, conversations with other SNF organizations to measure their interest in participating. And we actually got one other one added, and we started them in December. And then we got another one added, and we started them in February. But also there are disruptions related to state audits, COVID outbreaks. We have several COVID outbreaks right now, staff turnover, and so on. And then finally, just one last thing. These are just very large stakeholder feedback that we've gotten examples of. And, I can't stress enough about regular engagement with the sites themselves, making sure you have an engaged organization champion, which we have. But this is the critical one I wanted to point out. We had a professional stakeholder advisory board, and one of the members suggested that participation in this study could support their quality assurance and performance improvement activities that's mandated by CMS. And this could potentially help their participation in the study, their study performance. And so we created a certificate. We sent it out to all the sites. They told us they like it. They're excited about having this and showing during their monthly meetings that they're doing something related to the QAPI. They call it QAPI. And so we are in the process of designing monthly reports to send to the sites to show their study performance and showing that it's aligning with QAPI. So that is a really, I think, important suggestion that we got from our stakeholders. This is our options team, and I will stop here and allow time for questions.
Thank you so much, Denise and Sarah. We're running just a little bit behind, but we'll take a few questions or comments if anyone has one. And if they, Esteban.
Yeah,
please.
Thank you. Hi, Sarah and Denise. Thank you very much for that presentation. It was great. I was curious, especially around those last slides about initiating treatment for osteoporosis in skilled nursing facilities. If there's any evidence of, or if you've seen any increase in facilities starting medication like zoledronic acid, is it like is there any like feasibility or actually any evidence that the facilities are doing this? Like now we know that it's a medication that's it's safe and it's effective to use, but I think there's a lot of angst around it, and there's a lot of misinformation about it. So just curious about your thoughts on this.
Esteban, it's great. Oh, sorry.
I was going to say that we've tried to focus on this a lot, right? Because we're trying to improve bone active medication use, but we kept hearing over and over again, oh, we're going to be really, I don't know that we're going to be able to initiate any medications because it counts against our per diem payment, right? So that was a big one. But actually, we're not finding that as big of a barrier as we kept hearing it was going to be before we started. They seem very open to providing it once they buy in that it's important. But I will say that zoledronic acid has never come up as an option. A lot of them don't have the ability to do infusible products like that, and they wouldn't ship them out to have them do that. And so they're really tending to focus on just the products that are the most commonly used. So yes, I agree that there is a lot of hesitation with the side effects. So I don't know if Sarah's experience is the same.
Yeah, I would say they don't have IV capability is the problem. They would have to call somebody and pay for somebody to come in to put the IV in. It's not really the cost of the drug. The drug is pretty cheap, but the cost of getting somebody to come and put the IV in, they're not going to do it in the facility. I can tell you, so of the probably 1,200 or so patients that have been randomized to either the bone or the combined arm, I mean, by and large, we're recommending alendronate because we can get it started in the sniff. But there certainly are patients with dysphagia, adherence issues, other ones where we're recommending zoledronic acid, but we have to call out to the primary care providers and get them to put the order in for an infusion center as opposed to the sniff themselves doing it.
Great. Thank you.
I wish we could start it on everybody. Really.
Yeah. It's a
Yeah.
one and done.
Yeah, exactly.
Here.
But Esteban, I will say thanks to your and others, we do have several Massachusetts facilities, and sometimes we're seeing patients that have been treated, which is really nice in the hospital. So thank you.
Thank you.
Thanks so much. I think Sarah is alluding to a study that Esteban has done in the Harvard system showing the efficacy and practicality of administering zoledronic acid to hip fracture patients while they're still in the hospital in the few days postoperatively. I'd love to keep asking questions. I want to say two quick things beside thank you. One is Jay Magaziner pretty much has made the first half of this program possible. And, he has been such a mentor to so many of us, even just on this meeting, and just wanted to say thank you for introducing us to these clinician scientists, Denise, Sarah, and Rozalina. So thank you. And the other thing I wanted to mention is you may or may not know that there's a new payment model that's been required by CMS for payment of 5 different conditions. And one of them is the surgical treatment of hip fractures, and it's called TEAM. And it's a bundling reimbursement scheme that includes the 30 days following a patient's admission for hip fracture. And I was thinking a lot about how unbelievably coordinated the care seems to be that you're able to provide in these SNFs or afterward. It's really extraordinary for facilities that are and patients who are so complex. But partnering with SNFs is going to be really, it always has been important, but it's going to be even more important when we're trying to figure out best practice and value-based mechanisms for care and reimbursement. So thank you. All right, we're going to move to the next section, which are shorter scientific presentations. And let me see, the first one is on the effect of osteoporosis, bone health screening, and medication management on complications and reoperations following total joint arthroplasty. And this is being presented by a medical student from the University of Arkansas, Tera Scott.
Yes, thank you, Dr. Switzer, and thank you for letting me present tonight. I'm going to share my screen real quick. Let's see. Okay, are you able to see it? Okay, perfect. So I'm going to be talking about kind of the impact of osteoporosis on complications following total joint arthroplasty, as well as kind of the use of BMD screening through DEXA and CT scan and kind of medication management for osteoporosis. So I don't think I really need to give kind of a detailed explanation of what osteoporosis is, but sorry, for some reason, there it goes. Okay. But kind of in the context of total joint arthroplasty, the reason it's kind of important is because it impacts about 25% of these patients and places them at an increased risk for implant complications and also mechanical failure and fracture down the line. Despite this, previous studies have shown that bone health evaluation and optimization are not consistently incorporated into routine preoperative arthroplasty care. So kind of the purpose of this study was to first kind of evaluate the association between osteoporosis and early and late complications following both hip and knee arthroplasty, and then second, to assess how bone health is being evaluated and treated before surgery in this patient population. So to answer this, we did a retrospective cohort study using the Pearl Diver database, which is a large national insurance database. And to build our base populations, we first identified patients who underwent total knee arthroplasty or total hip arthroplasty based on CPT coding. And then within these groups, we stratified them based on osteoporosis status, based on ICD coding. So there are some limitations with this being based on coding and not like BMD scans. But once we had our groups, we matched them based on comorbidity, burden, age, and gender. So then we got our final populations that we did kind of more balanced postoperative outcome analysis on. So it's not shown here, but before matching, osteoporosis patients were significantly older and more frequently female, which is consistent with kind of the known epidemiology of osteoporosis. But after matching, these demographic differences were no longer statistically significant, kind of allowing us to reduce any confounding variables from other comorbidities that may impact the complications that we looked at. So one of the kind of most important findings in this study was the low rate of preoperative bone health optimization, which is kind of what we've been talking about with these earlier presentations. So only about 30% of the osteoporotic patients underwent BMD screening within 2 years prior to their surgery, and just about 13% received osteoporosis medications prior to surgery. And this is kind of particularly notable because all of these patients already had a documented diagnosis of osteoporosis within this time frame, so they were already kind of identified as higher risk patients. And this kind of highlights a significant opportunity for intervention for orthopedic surgeons to kind of be the first ones to make an impact on this patient through kind of programs such as AOA's Own the Bone Initiative, and similar things like that. So integrating similar kind of bone health optimization strategies into preoperative arthroplasty workflow may help to reduce complications and also improve implant longevity in these patients. So that's something that may be important to incorporate into future studies, is kind of seeing how patient-reported outcomes change with these different initiatives. Looking at the 2-year outcomes after THA, the osteoporotic patients had significantly higher rates of pathological fractures and revision surgeries. And then the differences in paraprosthetic fracture, PJI, and aseptic loosening were significantly significant. So kind of from a biomechanical standpoint, this makes sense since osteoporosis primarily affects the metaphyseal and paroarticular regions of long bones, so areas that are kind of crucial for implant fixation and long-term stability. So when bone mineral density is low, the femoral stem can be less stable, leading to more micromotion, stress, and then eventually implant failure. For TKA, the osteoporosis patients had higher rates of pathological fracture, revision surgery, PJI, and paraprosthetic fracture, but there was no significant difference in aseptic loosening. So kind of the potential explanation for this is pretty similar to the hips, where poor bone quality in the metaphyseal region can reduce component fixation, making the joint more susceptible to mechanical stress and fracture over time. For the higher rates of PJI, while kind of like bone mechanics don't directly cause infections, so that can't really explain that the compromised periarticular bone may affect the soft tissue support and healing, which could kind of explain this association that we found. In addition to mechanical complications, osteoporosis was associated with increased early medical complications. So patients had higher rates of anemia and hospital readmissions following both hip and knee arthroplasty. And then wound complications were also significantly higher in the osteoporosis patients for THA or TKA, sorry. And this can kind of probably be explained by the influence of soft tissue and periarticular stability, which can impact healing and recovery. And this aligns with our hypothesis that osteoporosis not only kind of affects long-term mechanical outcomes, but also contributes to early medical complications and increased healthcare utilization, and is why it should be considered prior to arthroplasty. So, in conclusion, osteoporosis is a major risk factor for both early and late complications after hip and knee arthroplasty. But despite this, preoperative BMD assessments through CT or DEXA scanning and pharmacological optimization through bisphosphonates or vitamin D are underutilized. So, early identification and intervention through structured programs like AOA's Own the Bone or other similar programs represent a tangible opportunity to improve outcomes. And although these evaluations may increase surgeon workload and the upfront cost of care, these efforts might offset or be offset by reductions in downstream morbidity, readmissions, and reoperations. So here's some references, and thank you. I have my email here if there's any questions that I'm not able to get to, but I'm happy to take any questions now as well.
Thank you so much, Tara. That was great. Does anyone have a question for Tara? If not, we are running a little bit behind, but I will say that work in arthroplasty to better optimize our patients is only going to become more important as the population ages. And your study doesn't even, I don't think you looked at revisions, but I think for patients who are undergoing revision arthroplasty, especially not just the primary arthroplasty, bone optimization can make such a big difference. So thank you for that.
Thank you.
We're going to go to our next scientific presentation. This is going, I think Noah Stevens, is that right? Yeah. Noah Stevens is going to present on the implications of language barriers on postoperative outcomes among older adults with hip fractures from Einstein College of Medicine. And I think Noah is a medical student also?
Yes, I'm a
Great.
second year.
Wonderful.
Thank you for the introduction and for everyone for being here. I'm going to share my screen real quick. All right, is everyone able to see that?
Yes, we're good.
All right. Like I said, my name is Noah. I'm a medical student at Albert Einstein College of Medicine. And tonight I'll be presenting on behalf of Jessica Chao and our orthopedic team here at Montefiore. Today I'll be discussing the implications of language barriers on postoperative outcomes among older adults undergoing hip fracture surgery. So just as a little bit of background, hip fractures are among the top causes of disability globally, with some studies reporting one-year mortality rates approaching 36%. Over 300,000 Americans are hospitalized annually for hip fractures, and racial and ethnic disparities have been shown to exist within hip fracture care. Prior disparities research has really been heavily focused on race. However, language barriers can independently impact access and quality of care. And so Montefiore, as a hospital system, we serve a uniquely diverse population here in the Bronx, where nearly half of our residents speak Spanish at home, And this provides, a great opportunity to study language-related disparities. So the objective of our study was to evaluate postoperative outcomes in English versus Spanish-speaking geriatric hip fracture patients. So for our study design, we conducted a retrospective cohort study of 456 geriatric hip fracture patients that were treated surgically between 2019 and 2022. 342 of these patients were English speaking and 114 were Spanish speaking. And to determine the primary language, this was determined via EMR documentation of interpreter use. For our exclusion criteria, we excluded patients who were younger than 65 years old, those with non-surgical treatment, as well as those with pathologic fractures. Our primary outcomes were in-hospital mortality, 30-day mortality, and 1-year mortality. Our secondary outcomes included, many perioperative metrics and common complications as listed here. For statistical analysis, we performed univariate analysis followed by multivariable logistic regression, adjusting for demographics, comorbidities, fracture type, and socioeconomic indices. And now for our results, for table 1 here, we're looking at our patient characteristics, and we can see that Spanish-speaking patients at baseline had a statistically significant higher rates of dementia, diabetes, and a greater socioeconomic burden, as shown by the ADI and DCI measures. Now, for our outcomes data, we see that after multivariable adjustment, there was no significant differences in hospital 30-day or 1-year mortality. And we can also see that, the length of stay, time to ambulation, and follow-up rates were also, very similar findings. And, this shows that despite greater comorbidity burden in our Spanish-speaking group, the mortality outcomes in our study was equitable. However, as you can see with the one highlighted box here, our Spanish-speaking patients had a 2.4 times higher odds of postoperative delirium after adjustment when compared to our English-speaking group. And so kind of just going over our key points from our results, the first one is that we found no difference in mortality between our language groups. And, what could this mean? Why is this? So the lack of mortality difference may reflect institutional systems, designed predominantly for a Spanish-speaking population, such as what we deal with here in the Bronx. And this includes things such as bilingual discharge materials, a 24/7 interpreter services, as well as diverse provider workforce. And these systems that we've implemented here at Montefiore, may play a role in mitigating large disparities in these hard outcomes like mortality. Our second key point from our results was that Spanish-speaking patients had a 2.4 times increased odds of postoperative delirium. And so why could this be? Well, previous studies have shown that delirium is strongly associated with, long-term cognitive decline and an increased 5-year mortality. And so one possibility is, language discordance may impair reorientation, pain communication, and early recognition of cognitive changes. Additionally, phone-based interpretation, while it's very accessible for us here, may introduce inefficiencies in, high-risk elderly patients. Therefore, we can kind of conclude that language discordance may represent a modifiable perioperative risk factor in our patients. Now, some limitations to our study. This was a single center retrospective cohort study. It was reliant on EMR documentation. We only studied English and Spanish as languages. We didn't take into consideration other languages that might play, an important role. And Also, certain delirium risk factors, such as medication exposure, substance use, etc., were not fully captured within the scope of this study. And so, kind of to wrap things up and bring things all together, mortality outcomes were comparable between English and Spanish geriatric hip fracture patients at our institution. However, we found that our Spanish-speaking cohort demonstrated significantly higher odds of postoperative delirium. Clinically, this suggests that, while our institutional systems may protect against, major disparities in mortality, language still may influence cognitive outcomes in, our vulnerable elderly patients who, are Spanish speaking. And so, kind of considering the future targeted delirium prevention strategies, as I kind of mentioned earlier, may represent interventions that we can put in place to help mitigate this risk in the future. And I'd just like to thank the listed authors here who helped make this project possible. And I'd like to thank you all for listening. Happy to take any questions.
Thanks very much, Noah. That was just great. Does anyone have a question or comment for Noah?
I know
Yeah,
it. Yeah,
Lori.
Lori here. That was a great, really interesting. I just was thinking, I bet social isolation because they weren't able to communicate with a lot of the staff, maybe either if that contributed to it. Did anyone discuss any of that in your study?
We didn't really look at the social aspect of it. That's a great idea to kind of, dive into in the future. And it's a great point, these patients who feel like they can't communicate their needs or just have people to support them around them, they might have, worse mental health, and that can lead to, various other things. So that'd be definitely something we could consider looking at more in the future.
That is so interesting and so helpful. Thank you for doing that for this population. Really great.
Of course.
I just wanted to briefly comment that although I wasn't surprised by the increased rates of delirium, I was expecting also like an increase in your other primary outcomes like mortality. So I think that speaks a lot of what you mentioned of the structures that you have at your hospital in taking care of these vulnerable population. That was great. Thanks.
Yeah, I think we were also, a little bit surprised that we would have expected increased mortality as well. And, there's certainly been previous studies, maybe not on specifically hip fractures, but just in general that, kind of follow that pattern of, language disparities do increase mortality. But yes, it was very interesting to see that at our institution that was not the case.
Great. Thanks again, Noah. Our last scientific presentation is, oh, now I've lost Vanessa. I'm so sorry. Vanessa Delheim from Harvard, Mass General, I think, is going to talk about a physical therapy intervention called Up and Out to try to determine, I think, factors that may or may not allow for physical therapists to see patients as early as possible following hip fracture. Thanks, Vanessa.
I'm also going to present with her. We're going to kind of do it half and half. My name's Vanessa Farmer, too.
Wonderful.
Welcome. Yep, so we have no disclosures. So it's well understood that PT and OT services are proven to improve and accelerate functional recovery following hip fracture and surgical fixation. This is well supported by the current literature. Many studies commonly discuss the benefit of early mobility or early ambulation on functional outcome post hip fracture, and even our own PT clinical practice guideline for hip fracture treatment recommends frequent daily PT while patients are in the hospital and assisted mobility and ambulation as soon as possible post surgery. But Vanessa and myself, as acute care PTs, we experience many barriers when trying to evaluate patients and mobilize them post-operatively. These could range from patient to clinical to systems level factors. And we find that there is a gap in the literature in regards to discussing or identifying these barriers and how they affect like the timing of our evaluations and the treatment, the outcome of our treatment sessions of our intervention. So the primary aim to our study was to determine patient and clinical factors that are associated with the inability to participate in PT on post-op day 1 following hip fracture surgery at a level 1 trauma center, which has a geriatric medicine co-management service. And then a secondary objective was to identify PT documented barriers that limited progression towards ambulation during the acute care hospital stay. So we completed a retrospective cohort study. The patients that were included were over the age of 65, admitted between January of 2021 to December of 2023 with a hip fracture following a low energy fall. And our primary variable was receiving a PT evaluation on post-op day 1. For each patient, their medical record was reviewed to determine if, in fact, a PT evaluation occurred and was documented on post-op day 1. Otherwise, the earliest subsequent eval was recorded, which typically occurred on post-op day 2. Additionally, a Johns Hopkins highest level of mobility score was retrospectively assigned to patients on their evaluation, as well as their final PT session in the hospital setting to determine functional milestones that were achieved across their hospital stay. So we looked at multiple clinical and demographic variables. 368 patients met the inclusion criteria across the 3-year period. Some interesting things to note, majority of the patients were female, 53% used a device to ambulate prior to injury, which speaks to their prior functional status, even pre-injury. Majority of the patients underwent an intramedullary nail as the method of fixation. And on average, time from admission to surgery was around 18 hours. Of the patients included, 67% were seen by PT on post-op day 1, which is great. At least we are making a good effort to try and see these patients when it is recommended by our current literature. In a univariate analysis, significant factors that were associated with not being seen by PT on post-op day 1 included age, being non-ambulatory at baseline, having an altered mental status, having a diagnosis of dementia, IM nail is as the method of fixation, and then post-op day 1 falling on a weekend day as opposed to a weekday, which may speak to some more systems level factors like I mentioned. And then in a regression analysis, significant factors for not being seen by PT on post-op day 1, again, were age, dementia, IM nail as the method of fixation, and again, post-op day 1 falling on a weekend day. As I mentioned earlier, we also looked at barriers to progression during an initial PT session, which we categorized by pain, medical or cognitive, patient deferred, or other. So medical barriers could include things like the patient needed a transfusion or they were hypotensive. Cognitive barriers included things like agitation or delirium. The other category included things like staffing limitations. And then pain was quantified by a subjective rating of 5 or higher, which may have been associated with buckling or instability while weight bearing. And then the other Vanessa is going to take over from here.
So as Vanessa mentioned, there's clearly an implementation gap between the research and suggesting early mobility and what we experience in real life. 33% of patients did not receive PT with the following characteristics. We suspect older patients and dementia where cognition was listed as a barrier 11% of the time, that this could have come into play, as well as a higher likelihood that these patients were bedbound or had impaired mobility at their baseline. That goes into our PT decision-making on day 1 of where we focus our resources, and we're constantly thinking about somebody's rehab potential. IM nail was the most common fixation, and this is an interesting characteristic that arose since it hasn't been mentioned specifically in other studies. Medical barriers were listed as 43% of the time when a patient was not seen on post-op day one. And this may be because of higher transfusion rates and the timeline associated with transfusions, at least at our facility. Currently, labs occur around 6 a.m. and then a blood transfusion, depending on the labs, will be ordered around 8 to 9. And depending on if a patient's getting 1 or 2 units, that could start later 8 in the morning and then go into the afternoon. So while having a blood transfusion is not a hard stop to being seen by physical therapy, it's the other symptoms and accompanied hypotension that would create a barrier for PT seeing these patients. There was also a weekend effect, and while we know healthcare is a 24/7 institute, that staffing does change on the weekends. Not only physical therapy, but also orthogeriatrics, which can impact orders or clarification. And typically our resources are really dedicated to focusing on patients discharging those days over the weekends. In regards to barriers to progression of mobility, pain was listed 49% of the time. And really this encompasses pain greater than 5 out of 10, as well as the fear of pain patients describes. Some patients were under-medicated. They would often say, when I wasn't moving, I wasn't having pain. And so then when PT comes in, maybe they are pre-medicated, but they're not at a state where their pain medication is able to address background and breakthrough pain. Medical and cognitive barriers were listed 32% of the time, and most commonly this was associated with hypotension. Cognitive could have been one of two barriers, either escalating behavior as we went in to work with a patient, or lethargy, where we started working with someone and we were not able to stimulate them where they could actively participate. Other was accounted for 17% of the time, and this included fatigue, anxiety, and weakness. And anxiety was something that came up quite a bit and as we reviewed PT documentation, and something that would be helpful to look at in the future. The limitations to the study included that it was retrospective and that we already have the orthogeriatric co-management model in place at our facility, so there may be limited generalizability. And then future studies would be helpful to try to capture that anxiety component, as well as a proactive study looking at addressing the pain and medical barriers prior to PT so that we could see if that improves participation and progression. Patients most commonly achieved a 6 on the Johns Hopkins scale by discharge, which is taking about 10 steps. And many times we felt like patients could be able to do more if they were better optimized. So in conclusion, 33% of patients did not receive PT on post-op day 1, but 67% did. These were associated with specific characteristics as we described, and pain and medical reasons were the most common barriers that limited progress with PT. And I hope everyone's takeaway here is that these are intervenable, and there may be an opportunity for more proactive intervention in these characteristics. There also needs to be system level changes and to consistently deliver early rehabilitation after hip fracture. And this includes setting patient expectations, assessing upright tolerance and pain. Ideally, this is done prior to PT so that interventions can be done. And at our facility, there's been a few initiatives to try to improve nursing-led mobility, but it hasn't been widely spread yet, especially in this patient population. And then also from a PT perspective, it's hard in acute care with so many things happening, and where we don't have a standard time where we necessarily see patients. So from our perspective, trying to set that expectation with staff and the team can help to optimize patients prior. And we can take any questions.
Thank you very much to Vanessa's. I really appreciate the way you did the work and then you saw opportunities. That's just great. I think we'll take one question from Marissa, I believe, had her hand up.
Yeah, I just had a question. Do you ever stagger your physical therapy staff to come in later? So let's say like that patient getting the blood transfusion, that they would be able to be seen maybe at like 5 o'clock before dinner time or later, if you have them start their shift later?
We do. They're not specific to post-operative hip fracture patients, but we do have staggered start times to help with some of the PACUs. And then these patients, if we couldn't get to them during our regular hours, always go to their list.
Gotcha. Thank you.
We did a pilot for staggered start times, and it was not very popular.
We're a small orthopedic hospital, so it helps them when they initiated that on the late start days, especially when, we had a busy OR schedule. It just helped improve that day of surgery getting up. And then we've cross-trained all of our nursing staff to get the patients up the day of surgery if physical therapy cannot do it. So not 100%, but a good population does get seen. Thank you.
Great. Well, thanks so much to everyone for those presentations. We have our next session is breakout sessions, and we had initially planned for folks to choose two, but I think because we're running behind yet, I think we're just going to have folks choose one. And maybe what I'll do is hand it over to Fraser and he can help with the coordination.
Yeah, this is the select your own experience portion of our program. So we have four breakout rooms that we're going to send you guys to. You're going to self-select which room you want to go to. I've set the timer on 13 minutes to give our presenters plenty of time once you get into your breakout rooms to present their research. So you've got four rooms to choose from. Once I open up the rooms, you'll get triggered to actually pick which room you want to go into. I have them labeled by the room number and the name of the speaker. So if you guys want to take a moment and look at the various topics to be presented in rooms 1 through 4. And like I said, once I launch these in a minute, you're going to get to self-select which room you want to go into. Once you get into your rooms, we have a moderator assigned to each room that will just welcome everybody and just encourage the presenter to start. And then after 13 minutes, the room is going to end. You're going to come back, and then we have a quick business meeting that we'll do, and then let everybody get on with the rest of their evening. So, all right, hopefully you guys have looked at those titles. You've picked your room. I'm going to go ahead and open all the rooms, and you should be prompted to select your room. If I see that you have your pop-ups blocked for whatever reason or can't get into a room, I'll self-assign you. I'll just automatically assign you to one. So here we go. Hope you enjoy the presentations. All right, hopefully that worked and you guys are picking which room to go to.
I don't see where to choose.
All right, were you doing one, Julie?
Yeah.
All right, I'm gonna send you there now. Hey, babe. All right, we got some people coming back. The rooms are still up another couple minutes, so we will hold on and give everybody a chance to finish here. Looks like we just got about a minute and a half left, and then everybody else will join us if they go to full 13 minutes. So the groups are chatty, by asking, grilling our presenters, I think.
And Fraser, are we doing a second round of breakout rooms or?
We're not going to do a second round since we're a little bit over time. We're going to go right into our business meeting and then we'll conclude tonight.
Oh, got it.
Our business meeting will be short. I promise. I know we're at 10 o'clock already. You guys have given us quite a bit of your time already tonight. But you have some formalities to take care of for the end of the year. So
well invested time though.
Yeah, the content's been really good. What we may do is invite our poster presenters to maybe come on our podcast and record a little bit about their research too, so we can get their research sent out into our community.
I would just say that I've really enjoyed the student presentations. I think they're really great to have those. Yeah.
Terrific. It's a great platform for them.
Yeah.
Okay. They should all be joining us. They've got 10 seconds to join us now. All right. Welcome back, everybody. Hopefully those breakout sessions went well. You enjoyed them. Let me share my screen again. All right. As we mentioned before, since we are at 10 o'clock already, we're not going to do a second round of breakout sessions. What we could do, we're going to talk a little bit during our business meeting. It's only going to take 5 or 10 minutes to do this business meeting. It'll be short and sweet, I promise. But what we might do is invite our presenters to come on our podcast and record a podcast discussion about your research and send that out to the community to gather or share that information with folks that are unable to join us tonight as well. So with that, I will open our official business meeting for the year. Again, this will be relatively short, but wanted to take advantage with this audience to give you a little bit of background about the IGFS. You'll see our mission statement there. We were founded in 2012 and basically exist to elevate education and awareness around geriatric fractures. We have partnered with the Fragility Fracture Network globally under a memorandum of understanding to operate as FFN USA as well. So that's why you see a lot of our information co-branded. And of course, our mission fits very nicely with the mission of FFN Global as well. A quick finance report. We are a lean and mean organization, as you will see. Our balance sheet at the end of 2025 was $26,000. We did incur a net loss last year of $22,000, but that was expected. We had a large Amgen grant that we received in 2023. That revenue of $50,000, those expenditures accrued during 2024 and 2025. That grant program is now finished, so that excess cash has kind of washed through the accounts at this point, but that's why we posted a net loss. Our revenue last year was $32,000 and our expenses were $54,000. Again, $32,000 was kind of a typical revenue year for us, but we did have the excess expenses around the Amgen grant as well. We made a decision several years ago to not make membership or finances a barrier to membership. So our membership dues are super cheap. And you'll see that in a minute with a little bit of a plug to click a QR code to join officially. We hope you'll join every year and give us some money to continue our mission. You'll see we actually brought in $550 last year, so there's lots of room for improvement. Our certification program, which we'll talk about in a moment, did bring in about 31,000. Of course, that program does have expenses to operate as well. So the majority of our expenses went to the grant, the certification program. Our management company, again, runs it on a tight ship and a CPA and some bank fees. We have put, I guess, a flag in the ground again to have an in-person meeting that Dr. Sorch spoke about during our first night of this year's annual meeting. This does come with a commitment to secure hotel space and food and beverage and all that. So we're hoping for a really good crowd to come to this in-person event in Columbus, Ohio. It's going to be December 4th through the 6th at the Blackwell Inn. We're going to have a surgical skills course as well as a fracture care component. So there'll be a lab on Friday and then didactic lectures on Saturday and Sunday morning. Should be a fantastic program for all specialties and disciplines focused on geriatric fracture care. So the program committee has put together a fantastic program. We're just about to release that. We've got all the topics secured. We're just finalizing speakers for all the topics we want included, and then we'll go ahead and open up registration. So we're going to try and keep registration as cheap as possible, just to encourage participation, and we are actively seeking sponsors to offset some of the costs of doing this. So please help us spread the word about this conference, and if you know any industry partners or other entities, foundations, and things that may be interested in helping support the event, that would be fantastic. A few of our existing initiatives, obviously our educational programming and our core certification program are at the forefront of what we do. The FFN Global Collaboration, of course, is something that is ongoing. We participate in multiple meetings a month with them around regionalization and supporting education coming from their organization as well as ours. We do support our orthopedic geriatric fellowship programs, promoting research opportunities. And Naoko spoke about the Blue Book revisions that are taking a great deal of resources and focus to get those that Blue Book revised as well. So here's the membership. It's super cheap. It's $50 for any clinician of any breed or brand. And it's free for trainees to be a member. We would like you, even though it's free, to officially register. And so we have you on our mailing list and can send you information about upcoming events and opportunities. So again, we've kind of tried to make this as affordable and accessible as possible. I did want to recognize those programs that have received certification this year, either initial certification or recertification. You'll see them listed, and a complete list of our certified programs are on the website. There's also a link to our certification manual that you can download and look at how we run that certification program, kind of the measures we are looking at when we do review and provide certification. And then kind of the ongoing reporting requirements for participation. So the leadership is looking at adding some bells and whistles to this program to make it even more valuable for the programs that go through it. So we're hopeful by probably this summer to be able to announce some additions to that certification program as well. We do continue our partnership with the Geriatric Orthopedic Surgery and Rehab Journal. There's also our website, geriatricfracture.org. And then we do have a podcast called Silver Linings. And I believe that QR code will take you right to our podcast homepage. But for any of you that are interested in spreading information about what you are doing, reaching our audience as well, we'd love to have you come on our podcast and talk about your initiatives. I do want to thank Carmen and Megan for being our hosts on that podcast. And shoot, if you consider yourself a potential podcast host in the future, we'd love to have you participate in that as well.
We are actively auditioning. Should anybody have any desire, auditioning/recruiting to help us with the band?
Yeah, it's super easy. All you have to do is love talking about geriatric fractures. We end up lining up guests to come on and you just engage in dialogue, and our staff will record them and put them on our Spotify channel and send them out as well. So if you're ever going to publish an article or you have interesting findings or anything, we encourage you to just reach out to us. We can line you up for an interview and put you on the podcast. All right. Now we do have some formalities. So our nominating committee report, we do work on a 2-year cycle for all of our officers and board of directors. We did a call for volunteers for the board and appreciate those that have reached out to us. This is the recommendation as it stands from the nominating committee for y'all to review. And we will need a motion to approve this slate before we close business. But we do operate in a leadership line format. So your officers are all moving up one step. So Megan Sorich is recommended to move up to president, Lori Fitton to vice president, Esteban Franco Garcia to treasurer. We do have a vacancy in secretary. So we are looking to fill that, and we'll fill that probably by appointment in the coming months. So if you're interested in serving on the board, let us know. And we've got an opportunity, at least one opportunity for folks. And then Carmen will be moving to vice president. Our at-large
president. I'm going to move to past president. I don't.
Oh my
I
God.
don't need this.
Come on, we're going to recycle you, Carmen. Come on. Yeah, that is totally a typo. That should be past president. My apologies. As far as at-large members go, you have Tony Balsamo, Brett Christ, Patricia Donahue, Hans Moeller, and Zenwa Onyema, Teresa Swenson, Julie Switzer, Naomi Turner, and Jessica Wiseman. And then we have a couple ad hoc non-voting members, Jay Magaziner and Naoko Onizuka. So that is your recommendation from the nominating committee for the officers, with the one edit of Carmen being past president and not vice president. Is there a motion to approve that slate of officers and board members? Anyone want to make a motion to approve?
Motion to approve.
Motion to approve.
Thanks, Liz.
Second.
Fantastic. There's a motion and a number of seconds. All in favor, say aye.
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 Opposed, say no. Fantastic. So we will note that officers and boards have been approved, and congratulations to Dr. Sorch, our president of IGFS and FFN USA for the next 2 years. Dr. Sorch, congratulations.
Well, thank you so much. I am looking forward to a great 2 years, but more importantly, I'm looking forward to seeing everybody in person in Ohio in December. So look for your emails and start signing up, because this is going to be really fun.
Yes, thank you for that, Megan.
Thank you, Fraser, for a wonderful virtual annual meeting. This was fantastic. Thank you to all the speakers who contributed over the last 2 nights of this, and really, really grateful to Fraser and his team for all the work behind the scenes to get this through to fruition and getting the CME credits and all the things up in a row. So thank you especially to Fraser and the team around getting that together. And also thank you to the scientific committee who helped put all of this together.
Absolutely. Thank you for that, Carmen. It's our pleasure. And you'll see this QR code in the bottom of your screen. That will take you right to the evaluation forms, which is how you can get your CME. So I'll leave that up for a minute. We are going to email everybody that participated on the first night and the second night as well with that link. So you can also do your CME certificates that way as well. And then once we get your eval back, we'll email you guys a certificate. So I'll leave it up for a minute.
And then Hans had his hand up. I don't know if Hans, do you still have a question?
No, I don't. I was just going to say it was a great meeting and really enjoyed it, and wonderful presentations. A lot of hard work by you all, and so appreciated. Thank you so much.
Yep. And we will be sending you a recording of both nights via email as well, so you'll get that too. And again, we exist as a small community, but we hope you'll help us spread the word to colleagues and peers that want this information or should have it.
Great. Thank you so much.
Brings
Brings our amazing annual meeting to an end.
Thanks, everyone.
Thank you.
Thank you.
Good night.
And I want to also quickly recognize Carmen for her great leadership and stepping up as the president of this organization for the last year and a half. It's been great.
Thank you. Appreciate it.
Yep. And
happy to pass the torch.
I can't let you go, which is why I made you vice president again.
I know. I was like, oh, it's going to start over the cycle on me. But also thanks to Julie, who has been literally a very very supportive and integrated past president the last 2 years as well. So really appreciate everybody and our lead and mean organization. Good work, guys.
Thank y'all. Have a great night.
Good night,
Bye.
everyone.
Good night.